Hi, thanks for the invitation, Dr. Srinivas Rajgopal. And continuing from the last talk, it is actually important in all those aspects to get a safe surgery. If you are prepared well, you know what you are dealing into, and all the surgical and hospital factors. And this becomes even more important when we are dealing with something like portal vein thrombosis, and because getting the right amount of portal flow is very important for that liver to work. Particularly in live donor situation, the right amount is even more important because too much of flow can actually damage. But here in the situations of portal vein thrombosis, the problem is trying to get the adequate flow, preferably a physiologic flow, which I'm going to talk about what I mean by physiologic flow and how we can achieve that. So it is a significant problem in terms of liver transplant, and the reason because of that, till 80s, it was thought this is a contraindication for liver transplant. Anyone having a portal vein thrombus should not be transplanted. Till 1985, the first case of portal vein thrombus was done by Professor Starzl, and he published. And after that, people started looking at doing more and more complex situations. But you know what? How much is the problem of portal vein thrombus? In a well-compensated cirrhotic, obviously, the incidence is less. But as the cirrhosis advances, around 7 to 15% of these patients end up having portal vein thrombus. And to the surprise, at times during the surgery, you get an unexpected thrombus which was not there when the patient was being evaluated, and that is a bigger problem to have. Now, portal vein thrombus has been classified depending on the extent of the thrombus in the vein and how many collaterals and the quality of collaterals around. Most common classification which is used is Yerdle classification, which looks at the extent and how much blockage. Like if it is involving the portal vein with less than 50% obstruction is grade 1, 2 is more than 50%, then extending into SMV, complete SMV. But what it does not tell you is the surgical decision making based on this thrombus. But still it is most commonly used in terms of comparing the outcomes and analyzing what is to be done. Two other classification models, particularly Jamieson, and works on whether there are additional collaterals in terms of net. So grade 3 and grade 4, according to Jamieson, is involving the entire SMV, but with good collaterals available is 3, but with no major collaterals available is 4. But again, all these classifications do not look at another major component, which is SMV thrombosis. Now, another important aspect of portal vein thrombus is it can be progressive. So patients who are cirrhotic being seen in the clinic should be evaluated for portal vein thrombus. And if there is a progressive disease, it should be, or there is a high risk of possibility of getting a progressive disease, these patients should have anticoagulation or a TIPS should be considered. I'll be talking more on the TIPS component in terms of portal vein thrombus, where the role of TIPS is increasing in managing, in correcting the portal vein thrombus as well as in the pre-op settings. So as I said, wherever possible, anticoagulation or TIPS, until unless there is a contraindication. Now, what are the problems of portal vein thrombus when we are doing transplant? Definitely the dissection of the porta becomes difficult. There can be a lot of bleeding. There will be inadequate flow to the graft. Patients who have portal vein thrombus, there is data which suggests they have a higher chance of getting hepatic artery dissections as well, and the length of the portal vein, even if you do a thrombectomy, is smaller. So technically a difficult surgery to do. Now, as I was saying, there are two ways a surgeon can get exposed to portal vein thrombus. One is an unplanned scenario where when the patient was being evaluated, the portal vein thrombus was not there, or due to renal dysfunction and all, the angios were not done and it was a surprise at the time of surgery. Second is a planned scenario where you know there is a thrombus and you know the extent of the thrombus, which is comparatively, even if it is a higher grade, you go planned and you are able to handle it well. So most important thing is going planned whenever you are doing a patient with portal vein thrombus. Now, what are the goals? What do we want to achieve? Is any adequate portal flow, the best way to do it, somehow recanalize the portal vein, either preoperatively using a TIPS, or on the basis of scans, you can assess whether you can do a complete thromboendarterectomy, or you can somehow get a physiologic flow coming in through the splanchnic circulation. And for this, very important thing to have a multidisciplinary team with involvement of surgeon, hepatologist, and intervention radiologist work together to make sure the decisions are done when you're managing a complex portal vein thrombus. Now going grade by grade 1 and 2, most of these cases you would be able to do a thromboendarterectomy and able to get a good flow. And these patients should be continued on anticoagulation for at least a few months after the surgery to make sure there is no rethrombus. There are various operative techniques which have been defined. You can remove part of the vein along with the thrombus and suture it, or you can do a eversion thrombectomy where you can remove the thrombus from the vein, and for that various ways, various techniques have been designed. There can be eversion. You can use a spatula. Most commonly, what we do is we use a Watson chain instrument to separate the thrombus from the wall, and you keep on going down and take a proximal control using either by finger pressure or mobilizing the vein and get the thrombus out. In some situations, you might have to add on a balloon to remove the residual thrombus as well, which our intervention radiologist helps us in doing it ultrasound guided. So similar thing can be done in 3, but in some situations you are unable to remove thrombus or the portal vein becomes atretic. You can use a jump graft from SMV if the SMV is patent, or a graft from splenic to get the inflow. If you have a cadaver graft, a recent cadaver graft that can be used in our center, we do mainly LDLTs. We end up using the Dacron graft in this kind of situation to take a graft that goes in the mesentery of the colon and anterior to the pancreas, and that is used for anastomosis. So as I said, residual thrombus can be removed by the intervention radiologist on table using either a Foley catheter or a ERCP balloon. The Fogarty balloon is usually soft, unable to remove those thrombus, but ERCP balloon works very well in these kind of situations. And you make sure you get a good flow by doing that. And so doing this on table is a little challenging, but then once you get adapted to these kind of technologies, it is still possible. Now the most challenging ones are the grade 4, when the entire SMV is gone. Now you have to look at the options where to get the flow. So either you have a major collateral, which in 30% of the patient you might see a nice pericholedochal collateral which is there, which can be used, or there is a prominent coronary vein. These are the 2 major inflows which can be used. The coronary vein can be directly joined with the portal vein, or you can use a interposition graft to do that. This is one such case where the coronary vein was divided and was implanted. And the Verix is something which is very important in Verix. Is when you're using Verix, you make sure you do not separate it from the bile duct, because the surrounding tissue actually becomes the supporting wall. Otherwise, the varices are very thin. If you try to separate it, you might not be able to use it. So keep the ductal tissue around intact. Now, what we do is we avoid doing a duct-to-duct anastomosis, although some centers still use the duct to do duct-to-duct anastomosis in those situations. We prefer to do a hepaticojejunostomy in these situations. Now, there are situations when there is a significant splenorenal collateral which is there, or you can use a left renal vein in those situations to provide inflow to the graft. Or if there is a small segment of renal splenic vein which is patent, you can put in a graft between the splenic vein and the renal vein, and then use the renal vein as a graft in particularly Yerdle 4 portal vein thrombosis. But somehow you have to make sure there is inflow going on. Although the results are pretty decent when you have a major splenorenal shunt available, Only problem in these situations is the correction of portal hypertension takes a longer time, ascites remains for a longer time, and slightly higher incidence of renal dysfunction, which happens in these patients. But the problem happens in the situation where there is no major flow going to the left renal vein. Although there is an entity which has been described as a siphon effect that happens if you use a renal vein, the collateral slowly, gradually, but then that is playing with the luck. Might happen, might not happen, and these patients might end up not doing so well. So these are some of the alternatives. So whatever we have done till now is physiological, where we are able to divert the splanchnic flow to the liver. But in certain situations, particularly in unplanned situations where you get in and there is nothing of that sort available, either you do a cavoportal where there is no major mesocaval shunt is there. If there is a good mesocaval shunt, the cavoportal anastomosis works well, and which Zakis has first shown in 1995 that had worked very well in first set of patients, but later on in their own series, they showed all the grafts had a graft failure after that. So it is only when you can demonstrate a good collaterals going in, it works well, and other than that, it's a problem. And last and salvage situation is portal vein arterialization, which hardly works. It is basically playing with fire. You're lucky you might get away with it. And these are again the unplanned situations where you get in, because a lot of arterial flow going into the portal vein lead to more of fibrosis. So in these situations, if you know this situation well, the role of tips becomes very important, and which Shanavas was showing some of his cases like EHPV, the similar thing can be done in these patients planning for transplant. Even if you have a small segment of splenic vein, you can go transsplenic, open up the splenic vein and portal vein using multiple balloon angioplasties, and then put in a tips, and you can actually do a transplant 4 to 6 weeks later, and which is much better outcome compared to going in with no major collaterals available. So this is one such patient where only a small segment of vein was there, splenic vein, transsplenic, and the stent was placed, and the portal flow could be achieved. Now, the last resort in these patients, when you know there is extensive thrombus involving everything like SMV, splenic, the desperate situation is a multivisceral transplant. That is the only option to actually salvage these patients. So to summarize the portal vein management, this is actually a good table which Prashant has published in Journal of Hepatology, where looked at what are the preventive modalities which can be done, and if those preventive modalities, they have included tips also in that. And if there is a failure, depending on what grade, I mean, I pretty much talked about all these potential options. But this is one chart I felt could be a good reference chart to be kept in when taking up patients for portal vein thrombus. Another important thing to be kept in mind is you have done a good surgery, you got a good flow, but these patients have a higher chance of recurrence of portal vein thrombus, whatever you have done. More so in those cases where you have done an extra anatomic inflow. So recommendations are, if you're doing extra anatomic inflow or there is a procoagulant stage, put them on a lifelong anticoagulation. Otherwise, you can have them for a short-term anticoagulation, and you can have the outcomes pretty decent. Only in 3 and 4, the overall outcomes are pretty inferior compared to the patients with no portal vein thrombus. In 1 and 2, you can actually have the outcomes similar to patients with no thrombosis. So we looked at our data as well, 5 years, 860 transplants. We looked at 800 transplants. 138 had portal vein thrombosis. Most of them won, and Yerdle 4 was in 7 patients. Most of these patients we could get away with removing the thrombectomies. And but when we looked at our long-term survival, other than Yerdle 4, our survival was same as patients with no portal vein thrombus. In 4, we had a 3-year survival of 71%, which is actually comparative to the literature. But then I feel going further, more and more, if the TIPS is being used, we can have even better survival. So my takeaways from today is advanced portal vein thrombus is no longer an absolute contraindication. Important thing is you have to customize the inflow reconstruction techniques, and a multidisciplinary team approach with hybrid endovascular and surgical approach is most important thing to manage advanced or complex PVTs. And then post-op care is also important in these patients. And I would like to invite you all for the upcoming annual conference of Liver Transplant Society of India in November in Delhi this year. Thank you.
A very nice and comprehensive talk, sir. It's completely covered the entire spectrum of portal vein thrombosis and the management. Preoperatively, when you said you want to, when you are evaluating such patients, do you get a clue from the imaging, like whether it's a soft thrombus or a hard thrombus, and then plan accordingly, during surgery?
So if there is evidence of chronicity, if there are a lot of collaterals around that area, if you see a calcification, you know it is going to be tough. But if you see a vein which is pretty much on a scan, if you see a normal thickness of the vein, you know it is a recent thrombus, and it will be easy to remove that.
Yeah, just one comment. During our Pittsburgh time, Professor Stargell has given a one on-table measure to get away low portal
You are not
flow.
audible, actually.
Yeah. So whenever you do a coronary vein as an inflow to the liver graft, if the portal flow after putting a Doppler is insufficient, so searching for a collaterals ligation in the background of Yardell's grade 4 portal vein is very dangerous. So he has given us some trick, we still follow that. What he used to say is partial clamping of the IVC with and without clamping. See that portal flow with the this great what is called coronary vein flow. If the partial clamping of IVC, the coronary vein flow to the liver graft is increasing, means there would have been a significant shunts are there. He used to recommend us to do routinely ligate the left renal vein to augment the collateral flow. So we still follow. That is easy because we have seen some of the time searching for collaterals in the background of extensive, making a bloody areas in multiple areas and coagulopathy, and you have to start anticoagulation. So you used to put a partial IVC clamping, see that portal flow is increasing, that means you ligate. If it is not increasing, don't do anything.
That's actually a good way when you have not done a scan preoperatively, and but if you have done a scan preoperatively, most of the time any major shunt you would be able to see, and you will go plan and make sure you ligate those collaterals to get adequate flow. And one of the reason of portal vein thrombus, if we look at that virtuous triad, is the slow flow, and somehow you have to make sure it's adequate to the extent that people say that you should ligate as many collaterals so that there is no chance of any diversion. Just in case there is a graft edema happens, it should not lead to diversion of the flow, and that to give an optimum amount of flow to the graft.
I have a question. With these tips, these are all CLD patients. Are you not having much incidence of encephalopathy?
Sorry?
With the pre-operative tips technique, are you not having much encephalopathy issues?
So it is like when you're doing in this kind of settings, and your aim is to do the transplant in next few weeks.
Time, okay.
And so even if, so this kind of tips, and Shanawaz is here, he can also talk about it. Even if someone has a history of encephalopathy, this tips is still advisable to get, because getting a good portal flow is most important thing. Another thing which is said is, if you see a patient with a portal vein thrombus and has a major shunt which is there and is going into encephalopathy, don't ligate those shunts because those shunts would be the only flow which is going to be available for you when you have to do the transplant. So I think even if someone has a grade 1 encephalopathy, you still go ahead and do those tips, because getting a portal flow would be more life-saving than...
I understand. One of the things that... sorry.
Yes. In So depending on what is the platelet count, how much is the coagulopathy that exists, and what are the variceal status, that is something we'll look at. So most of the time after TIPS, the variceal status comes down, and if the platelets are pretty low, INR is high, you don't need to anticoagulate, except on table single dose of heparin that can be given. But then if you're planning a transplant few weeks later, it is not required. Unless someone, a platelet count is higher, you might have to, or a procoagulant state. You'll have to balance the pros and cons. Not really, not really. Sir, you were saying something. Sir, you were saying something. So, sir, I think only situation is if we can't see any potential vein which can be used to give physiologic flow, and my IR guy says he cannot do any stenting, maybe that would be the only exceptional situation. Sorry?
No, there is a one Brazilians given this question answer. What they say is that Yardell's grade 4 portal venous thrombosis, where preopacity not showing any significant collaterals or shunts, but patient is having a mesenteric pain additional. So what we are thinking about gastroesophageal varices territory only, but SMV territory. So what they say is that Yardell's grade 4 portal venous thrombosis plus no significant shunts or collaterals. In addition, patient is having abdominal pain typical like mesentery. Such cases, they have listed for a multivisceral transplant.
That's understandable.
One of the new things that I don't know how many of you are doing it, the portal face of the CT, now I'm getting 3D reconstructions. Because if you look at it on an axial or a coronal, sometimes you don't know which is actually entering the renal vein. So if you do a 3D recon, you can keep rotating it and make sure in all planes the anastomosis is where you think it is and the shunts are where you think it is.
So that is what I said. This is actually a multidisciplinary thing which has to be done. Your radiologist, your intervention radiologist, I would say, is the backbone of doing these kind of cases successfully.
What would be your post-op management, protocols in looking at when you are doing a shunt, or when you are trying to do anastomosis with a collateral, let's say? How worried you would be in the post-operative that the shunt would be functional or non-functional, and how would you monitor those patients?
So in terms of anticoagulation, or
in terms of anticoagulation, also in terms of Doppler studies or imaging?
Dopplers are as it goes as per the protocol that we follow, and but anticoagulation, yes, we start anticoagulation if there is something zonal. We'll look at the TEG, and if permits, then we'll start the anticoagulation on table. And but if there is obviously a lot of ooze and all, we'll wait till next day. And as soon as possible, our protocol is we start the low molecular weight heparin. Fragmin is our preferred drug, and we start this on an IV infusion. So we started as for an adult 2500 IU over 24 hours. That means around 100 IU per hour. And then, the advantage of using fragmin infusion is you don't have to look at APTT monitoring, and it works pretty well in these situations. And then maybe shift to Xarelto after.
Sir.
So if I use collateral, I wouldn't use the bile duct. I would rather do a hepatic osteotomy. Yeah. So what? Yeah. So in patients who have a lot of collaterals, particularly large linorenal shunts, these patients usually till the end do not have significant bowel edema. So kind of working very well on that.
Dr. Abhideep, when this is very, very practical issues that we face when we use these collaterals. Like you said, you're doing hedges in these patients. The bowel function itself is very delayed. If you see in these cases, they go into that bowel edema is there and they don't tolerate feeds. We need to put them on TPN. There's a lot of translocation happening, sepsis, blood cultures become positive without even any surgical issue. So do you face these kind of things in patients when you use these coronary veins as inflow for...
Actually, if I have to tell you, we are a very low threshold hepatogenostomy unit. It is not just this. I mean, if you have two ducts, we'll make sure one is joined hepatogenostomy. I wouldn't use the duct for PSC. And if the recipient side of duct size is smaller than the graft, I would do a hepatogenostomy. So I have a very low threshold of going hepatogenostomy, and that has worked very well. And that is something which our anesthesia team has actually worked very well on that. So what they do is they keep on a very low fluid anesthesia, and that is something which is now submitted for publication as well. And all the boluses are given after the hepatogenostomy is done. So that actually helps significantly in keeping the bowel edema under control. So we actually are able to get a significant non-edematous bowel in most of these situations.
In the post-op period also, I mean, in our experience, we have seen there's a lot of, I think some amount of mesenteric is like congestion is always there in these kind of patients, and they give a lot of trouble post-op. I'm sure you faced it also.
So, I mean, as I said, the IV fluids, which we have seen a drastic change which has happened, and secondly, early portocable shunts. These are two things which, in a routine case, so that has worked very well.
And Dr. Abhideep,
No, I wouldn't say bad anesthesia. I would say fluid-restricted anesthesia.
I thought all complications are anesthetic.
Dr. Abhideep, any insights on doing a recipient hepatectomy in people with grade 4 PVTs and all? Recipient hepatectomies in people with grade 4 PVTs. Do you have any special techniques? Because they are very frozen portas, lot of collaterals, very difficult recipient hepatectomies. What do you practice in your...
So, particularly in situations like the collateral, my preference is to go around the porta, and this is something I have seen people from Seoul National doing that. So I just passed a elastic sling and twice and just pull it and just cut and then try and separate the artery after that. Because if you are doing the dissection on an early phase, it bleeds a lot.